This is a Compass MS Care event. My name is Stuart Schlossman. I'm president and founder of MS Views and News. And tonight, I want to let you all know that it isn't a Compass MS Care program. We do these in rural America and underserved communities around the United States. So we have for tonight's program, EMD Serono, Sandoz, Banner Life Sciences, Genentech, Biogen, Bristol-Myers, Squibb, Sanofi, and Novartis. And I want everybody to give them a round of applause because we couldn't do our programs without them. Additionally, for tonight, we had exhibitors of Bristol-Myers Squibb, Banner Life Sciences, Horizon, Genentech, Alexion, Janssen, and Novartis. And again, all of them come to our programs not just because of who's speaking, but because they believe in what we are doing for the MS community and providing these events. We have two different self-help group leaders from the local area, and they're going to speak for about 90 seconds each, all right? And they're going to tell you about their support group. Sharon, David.
Hi, I'm the leader of the North Charleston area MS support group. We haven't met in a while because my mom just died, but we meet every month. We talk about MS and everything, and everyone needs to come. I want everyone to come to the meetings if they can come.
Great, thank you.
Thank you.
Anything else you want to tell them about that group?
No, I thought.
You do?
Oh, we do. We do swimming. We do walks and everything like that. We do as a group. We do things together.
Great. Thank you very much. You can have a seat. Thank you. Next, we have Elizabeth Peterson.
I started an MS support group in Somerville in 2002, March, and it's been 20 years. And recently, I asked a couple in my group who are husband and wife, and the husband has MS and the wife is a caregiver. And I'm real excited. They've already started being co-leader. They passed their background check with the MS Society, so they're doing a wonderful job. My MS has gotten worse over the years, but when we started in 2002, we were coming way down to Medical University, and my husband was driving a van, and it was at night, and it was just getting real hard. So I talked to the person who was MS there, I think it was Gail, and we started the group. I'm hurrying. But we said we wanted it to be personal, and they said they wanted to get to know each other. So we've done that. You know, we've tried to just be friends. We feel like we almost can because we have MS. And it's been great. I think this month we had 21. During COVID, we didn't meet, but we started meeting in July in a restaurant, and it got real noisy. So we're back at Bethany Methodist, and I have some cards. And I'm looking around, and I think I have at each table at least maybe one person. Raise your hand if you're in the Somerville MS support group. Okay, so talk to anybody, and I made a card out with Rachel and Frank Tozier's name on it. So, and I'll give you my number too. I'll be an advisor, not a co-leader.
Thank you very much. They can come on and see you after the program. How's that? Okay, fabulous. All right, next we're going to have Dr. Walker come on up. All right, so he did a lot of virtual events for us, and Dr. Walker is the MS director at MUSC, correct? For the moment, okay, great. And Dr. Walker, like I said, he's going to stand here. He's going to speak to you.
First of all, thank you all for coming out. It is fascinating, fantastic, and awesome. And feel it right here. I look at each of these tables, and it's like my people, if you will. I've been fortunate to be in this area for 30 plus years and actually have created a situation where I have patients that sit in this room that become friends and colleagues at the same time. And Ms. Powell, thanks for coming. MS is one of those sort of circumstances, disorders that no one wants, particularly when you consider that for a lot of you, in a lot of situations where you have family members, it has created a situation, a circumstance to where you were young, otherwise healthy, and then you were not. And I think devastating from that point of view because of the suddenness of it. For those of you that are on the more mature side, you have that family member, that friend, that family member, sort of colleague as well, that might have had the stroke and sort of they were fine and then they weren't, but then they were old, so therefore somehow okay that something happened to them versus the young person. My youngest patient that I've actually treated and diagnosed with this particular disorder actually ended up being about, I think they were 12 years of age. So once again, this particular disorder doesn't discriminate based on age. There are people who are actually younger than that as well who have been diagnosed with it. Once again, this slide for you guys is elementary. You know this stuff already. That is an autoimmune disorder and so forth, and it actually has attacks and exacerbations and so forth. Okay. This is a very old slide, my favorite slide, but basically it attempts to give us a visual of what MS sort of looks like from a neuroimmunological point of view. And once again, the importance of it from a learning point of view is that they identify certain receptors, certain sites, and the medications that a number of you are using are actually targeting those locations. That's sort of the idea now. And the fancier the medication, the more targeting it is, and therefore leaving the rest of your immune system alone, ideally, in an ideal situation, in an ideal world. And of course, for most of you, you've had opportunity to see the photographs, the video of your, so to speak, MS, the lesions themselves, and these are different viewpoints of that. For some of you brought caregivers with you, and so therefore I do this a little slower, meaning that for those of you that have heard the term white matter disease, what they're referring to are these changes here, this stuff here, and of course for some of you, you've familiar with the term black hole. And that is these little areas here represent the so-called black holes. And these are just basically areas where the brain was injured and the wires, if you will, have been interrupted. And so the symptom could be something as word finding difficulty, memory loss, or more abrupt, can't move my right side, left side, that kind of thing, or double vision for that matter, or loss of sight. Any of those symptoms are possible contingent upon the location of those changes of those lesions. In my search and attempt to identify the most pertinent, newest information about the subject that we're going to do today, I actually came across this paper that was written in 21 that discusses in adequate detail an extensive review study that looked at sort of the concerns and issues of patients looking at access to care. And so we'll go through a number of different scenarios of sort of addressing that sort of symptom. And once again, what's the big deal? Multiple sclerosis in of itself is a chronic disorder, is a chronic circumstance. So therefore, as a result of that reality, inasmuch as you may have great intermediate periods, there have been moments of time where you need assistance, you need help, and contingent upon the age group to which you are affected, you may not be familiar with that. For example, if you're 16 years of age, insurance isn't something high on your list to have in advance of. On the other hand, if you're 60 years of age, by that time you're probably very familiar with the idea of insurance and how to acquire it and how to use it. And so therefore, we're going to go through some scenarios that tries to attempt, if you will, to address sort of the issues that people run into on an ongoing basis for otherwise chronic disorder. And so this particular paper, they broke it down to 5 separate sort of areas: information, interactions, beliefs and skills, practical considerations, and the nature of MS itself. And once again, the subcategories underneath that. But the idea being, ladies and gentlemen, trying to attempt to address it, because what happens is, for a lot of you, you're with the idea that we knew 20 years ago that there would be a shortage of neurologists in general. And then when you look at subspecialists in neurology, underneath that, people who treat MS preferentially, even smaller number of specialists as a whole as well. That number won't correct itself for another decade and a half, unfortunately. But the reality of it is that some of the complaints that you will see concerned, that you will see written here, talked about here, are tied to that reality as well. And then for some of us, the internet, video, Facebook approach to life is a little tough. You guys wouldn't realize this. I receive on average 50 new email, electronic thingies every day for the most part, 7 days a week. So it never stops. And once again, problematic in itself, to say the least. Okay, multiple sclerosis, symptom presentations, and of course, you guys are familiar with the rule. The rule is what? If you have a symptom that persists for more than 24 hours, it may very well be an MS exacerbation. If it's less time than that, then maybe not. But on the other hand, if you have a fever with it, then maybe it's not. Maybe it is a pseudo event, and your infection is causing a pre-existing phenomenon to occur. Once again, all these little subtleties, all these other little rules that are tied to what's a new event, what's an old event, all tie into this thing we call multiple sclerosis as a whole. And so then you get into the issue of just the unpredictable nature of the disorder itself, meaning that today you were great, tomorrow not so much. And for some of you, it's not a dramatic thing. It's just that today you have more fatigue than the day before. And of course, the most common debilitating symptom associated with multiple sclerosis isn't weakness, isn't numbness, isn't pain, isn't a defined disability in of itself. It's actually fatigue. Fatigue is by far the most common debilitating symptom associated with MS as a whole. And because there is no particular location in the brain that says, if you have this lesion, this location, that's going to give you fatigue, there's no such thing as that. We don't have that knowledge yet as to where and what causes it. We have patients that, for example, are doing fantastic, and then suddenly the fatigue kicks in. And there's no great therapy for it, even though for a number of you, you were exercisers in advance of the diagnosis or developed a system for exercise. And the studies support the idea that exercise works the best in terms of reducing the impact of MS and the fatigue component of it. However, what's the difficulty? For some of you, the exercise would mean the weakness in the leg returns, the dizziness returns, the balance issues return. So therefore, you want to exercise, you'd love to be able to do that, but then on the other hand, your particular condition sort of prevents you from doing that very well. So therefore, a difficulty in of itself. And so basically, what this next slide says here, frequent interactions, healthcare providers, people with MS continue to report unmet healthcare needs. Why is that, guys? Because it's such a large disorder. For example, you see the doctor, the clinician, but then you may also need to see the physical therapist, the occupational therapist, the speech therapist. And so all these other specialists that are assets for your particular care, for your particular situation, for that particular visit. Subsequent visits may not require that number of people, all those people, maybe some of those people. And I think that's particularly why people complain when it comes to MS about sort of the shortcomings of their visits, the shortcomings of what's going on with them, because they're not seeing all the specialists that they need to see. Plus, here's the other reality. A regular physical therapist is probably not going to be fully adequate because of the fact that there are actually physical therapists that specialize in MS. There are actually urologists that specialize in MS. The majority don't, but the point being is this, is that there's another slide that's going to come up later, I should say, where you, the patient, will present to a given healthcare provider, and you end up educating them on what MS is. And it fatigues you, it tires you in and of itself, that constant uphill push to try to get them on the same page so that when things come up, it's not automatically your MS. My arm hurts, it's your MS. My leg feels funny, it's MS. It's raining outside, it's your MS. I'm kidding, but the point being, but you get the point. The point is that whatever is wrong with you, somehow or another, it ends up being those two letters, your MS. And of course, you're very aware that's not always true, and that's part of the difficulty that we all run into, those who specialize in this disorder. And what this slide is showing, guys, is the other stuff, right? So you come to my clinic and you begin to discuss your teeth. I might look at them. Hopefully they're still in your mouth, but short of that, I'm not much help on your dental problem. But this is part of the medical care circumstance, because not that MS in of itself affects teeth, but it can affect the movement of your mouth. It can affect the sensation within your mouth. And depending on the situation, you may have pain in your mouth. It could be originating from your teeth, but it could be originating from nerve injury involving your MS as well. And that's part of the difficulty, trying to delineate which is what and trying to find that dental specialist that's willing to put in the work to confirm what is and is not true. Once again, the issues that you run into. And of course, the urinary tract infections. Common. Issues, circumstances. If it's just a urinary tract infection, then ideally no fever, but if there's a fever, then you may actually have more involving the kidneys themselves and then needing the urological evaluation as part of that circumstance. And then, of course, the physical aids and adaptive tools. And, of course, everyone is aware of the cane, the walker, and so forth. Once again, different tools that change. And of course, you may initially just need a walker and then maybe a manual wheelchair, but then given time, you may in fact need the power chair as well. And there are those who are specialized to assist you in that regard. Once again, when you come to the visit, are those people available to you immediately? And then, of course, understanding just how the healthcare system works. And this is the part of that slide I mentioned earlier, where you have that person who's 12, 13, 14, 15, 16, and hopefully they have a caregiver can assist them in that regard in the system, but not always. And then, of course, if they have no insurance, then you get into the Medicaid type stuff, which gets into funding issues as well. Once again, information, issues, circumstances. And this is the slide I mentioned to you guys earlier, where patients were sort of unnerved by the fact that they have to sort of educate their caregivers from time to time. Once again, uphill climb. Interactions, guys, the tough one, right? So I was working with one of my primary care doctors not too long ago, and he had informed me that it becomes standard of care in certain primary care situations where a follow-up patient time is 15 minutes. A new patient visit is 30 minutes. That's devastating. I have no idea how they would manage a patient with MS in that timeline when it's MS, but I need to talk to you about my leg. It's MS, I need to talk to you about my memory. It's MS, but I need to talk about my sight or my double vision. It's MS, I need to talk to you about my bladder and my bowel issue. But it's all still MS. But can you do all of that in 15 minutes in a follow-up? And so, like I say, this is what they say right here. Interaction is the fact that time becomes this major, major issue as well. Addressing your MS, but then you have all these other subtleties that are part of the same situation. Fortunately, in neurology, we don't have those restrictions, as you guys know. I may be running late, but I take all my time in the world with you, as you know. And then there's the interaction, guys, right, where we, the healthcare provider, doesn't always listen. We're sitting there, you're speaking to us, that's your goal, but we're not listening, we're not hearing you. And that's not unique to MS, right? That's sort of a situation sometimes with any number of other disorders out there. But that's the goal is yours, that you're listening to me, granted, is this X and so forth, and we go through that process. And ideally, hopefully, you remember that I'm always listening. I may not have the right answer, but I'm always listening. Then, of course, people are sometimes embarrassed by their situation. Some people have a tremor. Some people have a movement. Some people have issues where if they try to feed themselves, they're dropping things, and therefore they sort of shun away from the public in those circumstances because of it. And of course, given their natural original personality, they prefer to be out in public, they prefer to be out, and so therefore this creates its own medical circumstances from a psychological point of view and otherwise. And so therefore this slide is once again, so once the healthcare provider to begin to address these kind of issues and ask the question, are you still going out, are you still doing those things? Once again, the importance of sort of a global approach to that patient. And then there's the beliefs. This is a tougher one. Some of you bring herbal meds to the visit for discussion, and I have no idea what you're talking about. And the truth of the matter is that we really don't know how well these work or don't work, but then you make sure that you educate me on how you think they work. And you could be right. Who knows? But once again, the key thing here, guys, is occasionally I can get you to do more than you thought you could do. And this slide is really about that, right? We know that the patient who is active, remains active, tends to be active longer than the patient that is sort of woe with me and is giving up. You guys know that I live life glass half full. We didn't start off that way. That's where we are. And those patients who function glass half full, irrespective of they're in the power chair, irrespective they're laying in a bed primarily, irrespective, those patients, for whatever reason, seem to do much better when it's all said and done. I believe that patient, through his or her sheer energy, is able to tap that internal endorphin, that morphine stuff that's internal to each of us. if we can figure out how to tap that. And they feel better in general as a result of that person sort of reduces that fatigue, in my mind, through that same mechanism as well, through exercise. I think all these things matter. But the point here, ladies and gentlemen, is that those who have figured out how to live where the glass is half full tend to do much better. And that's where the belief system thing comes into place as well. And once again, we don't know it all. I mean, the most primary thing about MS, we don't know. We, to this day, do not know what causes the disorder. That's huge. It's just hard to cure something when you don't actually know what causes it, when it's all said and done. We've got a sense of the mechanisms that are affected, and we figured out medications to target those mechanisms that are affected, but we haven't figured out the primary thing. What causes multiple sclerosis? We don't know. And once again, a difficulty when it's all said and done. And of course, this is the time component where you come to the visit, and the patient, of course, often in a wheelchair, sometimes in other sort of mechanisms for transport, and they're uncomfortable. And the doctor's delayed, the patient's delayed, and therefore can't remain, can't stay. And so therefore a barrier, if you will. Once again, things that we need to do. Sometimes these waiting rooms, the chairs aren't big enough. They aren't high enough. They're not designed well for a population of patients that actually have more needs. Often, some of you are familiar with this, and you bring your own items that allows you to sit and be comfortable, at least for a reasonable amount of time. But once again, we as healthcare providers need to begin to redesign these waiting areas, make sure the doors are appropriate. Heck, make sure the bathroom is appropriate. Once again, usually it is, but not always. And amazingly, the number of public buildings that I've been in, that they don't have facilities for people that have special circumstances, if you will. In time, patients learn to self-assess, meaning that evaluate themselves and come to a conclusion that I agree with. Sometimes you come to a conclusion I don't agree with, and we discuss it, and I try to convince you that I'm right. But nevertheless, the whole point, guys, is to assess an assessment of self, determine what your needs are, and then move forward from there. Sometimes what that requires on both our parts is the addition of the physical therapy. They say, you know what, you want to wear this, but you also need this. You want to wear that, you need this. The occupational therapist who comes out and says, you need this tool, that tool as well. Once again, a team effect. And ideally, we will someday have that at MUSC as well. But certainly, as we move towards that, I want you guys can think in that way that we need a team approach to take care of me. And typically, as a general rule, that is what an MS patient needs in time. Now, some are fortunate in that their situation is minimal, meaning that they had a gait disturbance and they never have more than that. And there are those that are fortunate. But most tend to get more than that as a general rule. And then, of course, there's the mood component, right, where we need to figure out what components. There's depression because I have MS. There's depression because I inherited a tendency for that. A number of MS patients, for example, have migraine. Migraine in of itself is a disorder that, in such a case, that mood changes like depression, anxiety, I inherited with migraine. While on the other hand, to be honest with you, MS, that is not a situation. But a number of patients with migraine happen to have MS as well. And of course, this we saw earlier, wait times. Let's do the last one, finances. The university in and of itself has a financial counselor. And I think they work well when it's all said and done. I think the shortcoming is on the medication piece. To be honest with you, my Mrs. Powell and my admin assistant are probably better attuned at managing the financial part of it when it comes to the medications themselves. Unfortunately, there's different situations in that regard wherein how you are funding interferes with how you and what medication you may get. That's what I would write and suggest that you and I agree to. However, your financial institution, insurance company may feel different about that. And they're still more often than not doing what I call step care, i.e. you take this medication, if you fail, then this one you fail, now you get the one you actually wanted. And that's termed step care. And so therefore, versus stratified. And so therefore, an issue. But once again, it's the reality of how things are done. And this slide just wants to make the point. comprehensive evaluations wherein you have a situation where you have your neurologist, you have your physical therapist, occupational therapist, your dietitian if necessary as well. I actually did a talk a couple of days ago on what I call the microbiome. And the idea there, ladies and gentlemen, was that within our gut, there are what they call flora, what you might call bacteria and fungus and so forth, but fancier word is flora. Sounds nicer somehow. And when food items, medication items are exposed to this group of organisms, if you will, they break it down and often create a positive circumstance within your gut system. Occasionally not so, but that's the general idea, and in turn, microbiome. The study was looking at trying to determine if a patient has, in this case, MS, the person living in the same household with them, eating the same food as a general rule, is there a change associated with them having MS? It turned out that there was a little bit of a difference, but it didn't seem like a clinical difference in that patient population. But it was interesting, the idea of the research in the look itself. The medications, some of them changed the microbiome pretty dramatically, and yet the patient's outcome still didn't seem to change, but it was sort of, once again, still an interesting idea. Okay, let's change pace a bit. Decision making. I love decision making. I love making the decision. The 12 so-called myths. So decision making would go away. Of course, you guys are well aware of the fact that did not happen. When you come to my clinic, and pretty much any physician's clinic, I hope, you sit there, you decide, okay, I have this issue, this is my memory problem, these are things we can do about it, we discuss that, and then you decide what you want to do, and then you move forward. And that's the idea, and that's decision making. That's continued to be the case. It's been present forever, and I think it's going to continue to be the case as well. It's not going to go away. Occasionally, depending on the patient, they will delay. And there are reasons for that. Because they want more information. And if you got a 15-minute visit, a 30-minute visit, there may not be enough time within the course of that particular visit to actually create the situation right in that space. So therefore, you create a situation, a deal is made, and they then leave, come back, or leave, and then inform your court later. And that is fine. Because in most circumstances, there's no emergency, there's no super urgency when it comes to this particular disorder, but you need to decide. Occasionally, we've had the patient that is supposed to come back in 2 weeks and came back in 2 years, but it's okay. It took long for them to read it and took a time to decide what they want to do. And sometimes they came back not because they really wanted to, they came back because their spouse made them, just to encourage them, or they had a new symptom they were attempting to avoid. It happens. It happens. And so as a result of that reality, problematic sometimes. Sometimes the new symptom isn't substantial, isn't major, but sometimes it is. Once again, they came back. And we sit and we discuss where they are, where they were sometimes, more importantly, where they're going. And that's where they go there when it's all said and done. And of course, number 3, not everybody wants to share the decision. Some folks say, it's my body, my decision. And I say, yeah, it is your body. I want to be my decision, though. but they're 100% correct. When it's all said and done, it is their decision. My job, when it's all said and done, is to give them the pluses and the minuses. And then when it's all said and done, ideally, they've decided plus, okay? Because here's the thing. Ultimately, they take on the risk. If there's an adverse effect from the medication, they take on the risk. The non-compliance, meaning not taking the medication when you should, how you should, and so forth, can be as dramatic as high as 78% of the time a patient does not take a medication when, how they should. And I think part of that's because we may recommend something, didn't necessarily discuss it in a way that they understood or they wanted to hear, decide not to do it. They come back and have 2 choices. Doc, I had side effects from the medication, never took it. Or they had side effects from the medication. Now they're mad at you. But in either case, the point is that the discussion needs to happen and the decision needs to be made as well. And number 5 is interesting because some patients love asking me, so if I were your son, if I were your daughter, what would I get? I give them an answer, the best. Occasionally, I'm in an analytical mood, and this, of course, my daughter's African American, and the person sitting in front of me is not. And to be honest with you, the medicine I would give her is not medicine I give you, because there are ethnic differences in these medications. In some cases, there are gender differences in these medications and how they work. And so sometimes the answer is not what they anticipate. But the goal here, ideally, guys, is that we give you the best that we think you can tolerate. Some of us want medications. Walker, this one causes cancer. Are you suggesting that you're going to get cancer? Well, the cancer risk for most of these medications is tiny, it's minuscule, to be honest with you. But on the other hand, if you've had a cancer, I get that. And so once again, the point is to make an informed decision when it comes to these medications when it's all said and done. And of course, number 6 was a given we discussed earlier. Too much time. It happens. Okay, let's skip number 7. Let's go to number 8, the tools. The tools just means, ladies and gentlemen, ultimately that you are, in this case, we may ask you to look at the National MS Society website where they keep it up to date as a general rule, and they have most of the MS medications listed there. They have a lot of situational circumstances situated there as well, and therefore a good initial resource to look at when it comes to medications and it comes to lifestyle circumstances as well. And then people that you want to talk to, converse with, who actually, in some cases, actually have MS, which again, you get this broader view of a potential sort of look in future as well. So then once again, the resources, the tools. And of course, we're always familiar with the reality that there is the doctor, the patient, the caregiver. And the caregiver can vary from the spouse themselves to very, very close friends, but they are a part of that decision making depending on what you're asking. Something as simple as the doctor visit is on so-and-so date, the patient themselves does not drive. Can that caregiver, that significant person, get them there on time? Get on that particular location, that particular day? Once again, all these are sort of part of that spectrum of the things that are included in the decision when it's all said and done. And then, of course, number 11, the cost of things. These medications are expensive. Pretty expensive. And the mechanisms of getting it paid for, you as the patient may not be familiar with that. So therefore, our team has a number of individuals that do that work and sort of push that hurdle for you as well. Once again, trying to make it all happen. And then, of course, there's the emotional aspects of the disorder itself. Who wants to have MS? Who wants to have any chronic condition when it's all said and done? But it's here, it's there, and once again, our jobs are to get you through that so you can live, well, my favorite new term, your best life. The initial medication was back in the early 90s, 91, 90 or so, and those were the injectables, those were the interferons, and they did their service, if you will. You didn't have much in the way of cancer risk associated with them as well, but the biggest sort of issue with them primarily was that they were all injectable, and with that issues. And of course, interferons in themselves has their own issues as well in terms of like flu-like symptoms and so forth. But once again, they had their place. And then there's clotrimate acetate as well, which is one of the many favorites, if you will. But once again, its claim to fame overall was that it's also an injectable, but also safe in pregnancy as a general rule. And then, of course, there's Consimta, which is a more recent addition, but also an injectable, and it is a B-cell depleter, one of the more recent medications in that regard. And then the oral medications. Abajo, actually, I'm told, will be generic shortly. And then Tecfidera is already generic. Gilenya will be generic shortly, apparently. And then, of course, there's Mayzent, which is more recent medications. And once again, all of these are oral agents, and they all have their place. And primarily, they all immunosuppress. The mechanisms in which they do that is different and unique to the medication itself. And then, of course, there's ocrelizumab and then natalizumab. and then, of course, Limtrada. And these are medications that are also infusible. And depending on your healthcare provider, he or she may relegate these to the more aggressive side, but it's not necessarily true. But that's sort of conceptually the case in most of these situations as a general rule. And then one Tysabri is probably tied more so to the idea of the progressive multifocal leukoencephalopathy, the PML, and we discuss it at the very end. Okay, recent developments, the new stuff that's potentially coming. BTK, Bruton tyrosine kinase. If you see here, it's a B cell depleter, but it also affects something called a microglia, which is another sort of immune complex molecule within the confines of the central nervous system. The first one that I could find seems to be something that's going to come in August of 23, the proposed date, even though it seems to me that I read where originally it was going to be sometime in 22, but once again delayed into 23. And its mechanism, its means of administration, supposedly it's somewhat unique. It might relegate sort of pluses to this that we haven't seen before. Once again, from a healthcare provider's point of view, it's something else added to the armamentarium. As I recall, there should be about 5 or 6 of this class coming, ultimately, different companies producing them. So once again, I look forward to this addition, if you will, to the medicine that we already do. And then, of course, there's stem cell, which has been around for a while. And we've had patients that have actually had stem cell treatments, and, of course, the different types of stem cell, if you will, in terms of the source. And for our patients, I haven't seen much in terms of ways of pluses, but I've read where people have had fantastic outcomes with this technique. In of itself, it is relegated primarily to other countries beyond here, but there are places in the United States that you actually can get stem cell treatment. I think that part of the issue with it is that people are potentially getting it late in their therapy as opposed to earlier in their therapy, and that may be affecting outcome. Once again, don't know that for a fact, but it seems to be seemingly the situation as a general rule. And the key thing to remember here, the way this describes it, is that your original immune system is wiped out and then replaced by this new sort of set of immune cells. So therefore, you have a new situation. And keep in mind, this would then mean that ideally that you should have no more attack from an MS point of view. You should get no worse, but it doesn't necessarily mean that you'll be better, okay? Because remember, think about it. So for a number of you, you have a situation wherein you have had the myelin damaged. Once it's damaged enough, you then will have loss of the nervous tissue underneath. If, in fact, you now have the stem cell done or some technique performed to which you now have no more immune complexes damaging the future myelin and allowing that damaged myelin to repair itself, the nerves underneath aren't repaired in that circumstance. So from a theoretical point of view, you would see a situation where a person would not get worse, but you wouldn't necessarily get better either because the nerves underneath weren't repaired. Once again, conceptually, it seems to me that's probably what the best you're going to get if you have more late-stage treatment with stem cell. Once again, we don't do that here in South Carolina. Okay, generics and biosimilars. So the general rule, which you will see printed in these slides, is that generics is simply a molecule that is essentially identical to the original molecule. The primary difference is that a generic, the active ingredient could be as little as 85% of the original or as high as 105% of the original. That's generic. A biosimilar is a different kind of sort of medication because the source of how it is made could be a little bit different. So therefore, it could be what you call immunogenic, if it would create an inflammatory response that the original molecule may not. So they are both sort of copies in a way of the original molecule, but how it's done is different. It's sort of the idea between these two. But they are both have to be approved by the FDA, so therefore safe they are. The only debate you may have is whether they are as efficacious as the original molecule. Okay, guys, so this last slide, PML, progressive multifocal leukoencephalopathy. For those of you that have heard that term, seen the commercials, have sort of wondered, what is that? What does it look like? This is it. So here's the idea. Top slide to the left that has an A on it. That is basically that big white thing there. That's the inflamed lesion, if you will, created by the situation of this positive JC virus, and then this immune system just overactivated, and now you have this damaged region. And then it enlarged in C even further. And so this individual, in theory, might have had slight weakness involving a part of their body, and then suddenly no movement at all. And given the size of it, they also may have lost consciousness as well. Once again, given this size. And then you look at the side over here, that's the recovery side, where you see where they have significant tissue loss. And so therefore, even at recovery, assuming they survive it, that person has lost a lot of tissue, so to speak, as well. Once again, I want you guys to get a visual of it. Okay, very good. Thank you. And I think it's question and answer time.
Thank you very much, Dr. Walker.
I just wanted to know, what's the difference between biosimilars and formulary? Are they the same?
Formulary, you mean as in, so formulary typically pertains to what a company or pharmacy has determined is always available to a given patient, given a certain pay plan, and that's on formulary.
That's not generic. I was told that it's different than generic.
So on their formulary could be generic and no branded. But that is a predetermined thing that typically changes every 6 months for a lot of these companies these days, what is formulary, if you will. And it could be, for example, if we're using a drug or medication, glutamic acetate, well, Copaxone, the brand may not be on their formulary, but glutamic acetate is on their formulary.
What is the pricing difference on generic versus brand?
Okay, so the question or comment was pricing difference between generic and branded. So historically, the generic or biosimilar is going to be less expensive than the branded. How much is charged is based on the insurance, is based on the state, all these sort of other sort of intricacies, if you will. Sometimes even what country you're in, for that matter. But biosimilars and generic are typically less expensive, which is why insurance companies tend to prefer them as a general rule.
Question, how is it that the pharmaceuticals are giving prescription assistance to those who have private insurance but not government insurance?
Okay, so fair enough. So, as I understand it, when it comes to the sort of commercial insurance, the pharmaceutical companies are allowed legally to then give them assistance, if you will. When it comes to government insurance, they are not. It's just rules that were put in place eons ago, and that is a general the case. And so therefore, if you have Medicare or Medicaid, then the insurance companies are not allowed to give you medication.
Okay, question from online. Which medication can be used to help block B cells from crossing the blood-brain barrier?
So the question comment, guys, is which one would sort of prevent them from crossing the blood-brain barrier? The one that has the most fame in that regard is glutamic acetate. It has the most fame in that regard because what it did, it would cause changes in the leaky sort of aspects of the blood-brain barrier, and then as a result, reduce the tendency for the pathological cells crossing through the blood-brain barrier. Others don't really fix the blood-brain barrier. What they do is, though, they reduce the number of white cells totally available, and thereby by sheer reduction in number of white blood cells that might cross, you still get the same general benefit. But to answer their question, glutamic acetate.
If somebody does get PML, what do they do?
So if a person does, in fact, the question coming is, if a person does get PML or progressive multifocal leukoencephalopathy, ideally they brought in immediately. if they were on a medication like, for example, natalizumab, or sometimes called Tysabri, they get pheresed, where their blood is removed and filtered 5 separate treatments that will remove all of the natalizumab in their bloodstream. They're then placed classically on high-dose steroids as part of their treatment plan, monitored very closely, and then they really adjust their medications according to the patient's needs, and it may, in fact, require intubation and being breathed for as well.
Second part of that person's question online is that they heard that there was a biosimilar coming out to replace Tysabri. What if the person wants to stay on Tysabri? What do they get their doctor to do?
So the question comment is if they, in fact, want to stay on branded. Typically what happens is the healthcare provider will write the new prescription, and he or she will check box as written, brand only. Occasionally the insurance will abide by that, and then they have their medication. Occasionally they won't abide by that and then say, okay, fine, the biosimilar is, I'm going to pick a number, $10. And the branded is $20. We're going to pay 10. If you're willing to pay the other 10, you can have your branded. I've seen that done. Occasionally, sometimes, if you write a letter of concern and explain it in exquisite detail why they need branded, occasionally that will pass. But typically, if they have never been on the biosimilar medication and had an adverse reaction, it is tough to get the company to actually pay for it unless you confirm side effect related to that medication.
Okay, thank you.
Okay, I know that with my treatment, aquatic therapy has been effective. So would the team come together and realize that that's a necessary part of the treatment?
That's a question?
That's my
Mr.
question.
Williams?
Yeah, that's the question.
Okay, so yes, sir.
For long-term purposes.
Sure. So the question coming, guys, is that the patient may, in fact, use aquatic therapy, and could that be something that's done long-term continuous? And the answer is certainly. Sure it can. Particularly helpful for patients with MS, because as a lot of you have noticed, if you get heated, then you get weak or you return to that prior symptom, which is termed UTOF phenomena. And so therefore, the pool in of itself allows a situation where it cools your core temperature and your external temperature. As such, it allows you to exercise and perform much longer than you would have otherwise. So therefore, the aquatic therapy is ideal in this particular setting.
What are the treatments for talking about nutrition and how it affects or can affect MS?
So the question comment, guys, is about nutrition and MS. So there is substantial debate on the answer to that question. What was interesting in that microbiome study is that most of the MS patients actually ate healthy. By far more fruit and vegetables than their housemate, if you will, was noticed in particular. And the effects of vitamin D didn't seem to make much of a difference in either situation in this particular study in of itself. There are 5 distinct diets that actually mentioned in the National MS Society website. One of them is gluten-free, one of them is the paleo diet, and a couple of other sort of Mediterranean diet and variations of that. And 3 of them have been confirmed to probably make a positive difference in the patient's disease state. So I think there's a place for diet for sure. There's a place for fitness for sure as well. I think all those things count as a part of benefit for the patient. As a general rule, most folks say they feel better when they eat well and they feel well, and their sort of body habit is where they want it to be. So I think all those things matter when possible. Yes, ma'am.
All right, next one from online. Mark asks, how long after or before my Ocrevus infusion is it okay for me to get vaccinated?
Okay, the question comment guys got heard is, when is it okay after ocrelizumab to be vaccinated? The standard rule is at month 4, at the end of month 4. Is when it's your window of opportunity. That's when the medications had its most significant sort of drop in overall efficacy. So therefore, in that time window, you're more likely to have a positive antibody response from the vaccination in that window.
Okay, next from online, a Debbie asks, when should stop one should stop using Tecfidera if you have tested positive for JC virus?
So the critical comment, guys, is that the person, I assume, has MS, one's on Tecfidera, tested positive for COVID in and of itself. You don't necessarily always have to stop your immunosuppressant medication. It depends on the level of illness that person has. If they actually present to the hospital and get one of the infusions that sort of treat them, some patients will stop their medication, but you don't always have to. But if you need to stop it, you would stop it immediately once you're diagnosed, and then you restart it 10 days to 2 weeks after you have no more symptoms. Once again, there are varying rules on this. There's no fixed rule. It varies from month to month, week to week, but that's sort of what people have been doing.
Hey, Paul is asking, is there a way to rebuild myelin?
The question comment is there a way to rebuild myelin? Myelin of itself is sort of self-perpetuating, if you will, as long as it's within that window and the inflamed sort of phenomena is removed soon enough. So the goal is, when you get steroids, is to remove that sort of inflamed phenomena early enough in sort of the course, and as a result, the myelin will repair itself to a large degree. And so typically it's pre-treatments. Are there medications that you take external that will actually rebuild it? None confirmed. The number who sort of allude to the possibility that it would cause that to occur, there's no evidence that that actually happens. But we do think that if you have an immediate exacerbation, they give you MRI, it shows contrast, it shows enhancement, you get the solumeter, all the steroids at that moment in time, early enough, it seems to reduce seemingly the inflamed response, and then the myelin will repair itself as much as it can.
Great, thank you. Next, over here in front.
Okay. I had COVID in January, and I had lost my right side already, and it took away my left leg now. And I've had physical therapy and just occupational therapy. Is there a chance that maybe it could come back even after all this time?
So, how long has it been, Ms. Elizabeth?
Since January. I had it January 6th.
Okay, thank you. So the question coming, guys, is that this young lady had a deficit from her MS in advance of, and then she got COVID, and then subsequent or during the course of that particular illness, she lost more in the lower extremity on the opposite side, suggesting, therefore, in theory, a different lesion from the original. And so now the question is, it's been 9 months or 9.5, 10 months. Is it possible for you to recover? Always possible, but not as likely. As you well know, typically you see recovery more likely within the first 90 days, and then you have 6 months, and then after the 6 months, the incremental improvements are very, very tiny. At the end of 12 months, if one hasn't seen an improvement, odds are you won't. So very reduced, but I'm sorry.
Great, thank you. Before I get back to the laptop, can you tell us about biomarkers other than MRI? Is there anything out there? And if not, what's to come?
So the question is about biomarkers. So there's a ton of different techniques looking for these idea of something that you can use to determine which of the 20 plus medications or techniques out there that would be ideal for your circumstance. Because right now we separate the medications based on their mechanism. There's those that are S1P, there's those that are fumarates, there's those that are CD20 medications and so forth. The interferon, that kind of thing is what we are now doing. And then doctors sometimes are treating you with one medication. If it works, let's say it's an interferon, it doesn't work for you, they don't go to the different interferons, they now move you to maybe a fumarate. If a fumarate doesn't work, they don't move you within that fumarate class, they now move you to an S1P. The point being is that's sort of what's being done now. The goal of a biomarker is, once again, to identify what is unique to your chemistry. They do maybe a skin test or a blood test, and they send it to the lab, and it comes back and say, you are A62734. That means that you would respond more likely to a fumarate, and then secondarily to a CD20, versus sort of experience and guessing. That is what sort of the idea is. They haven't identified well enough, consistent enough right now what those exactly are. But it's still, I think, coming, if you will. But once again, that's the goal.
Can you talk about children and grandchildren of adults who have MS and what the likelihood is that that will be passed on, and what might be done to prevent it?
Okay, cool. So the question comment is about inheritance, basically. As a general rule, most patients don't seem to inherit this disorder. I have a family of, my mom was one of 10. Each individual averaged 7 children. And with all of that, I have one first cousin with MS. The point being, ladies and gentlemen, is that rarely is it inherited. But it does happen. I have father, daughters, mothers, daughters, sons, boys, girls, brothers, sisters, and so forth. So you have those combinations. They're out there, if you will. But as a general rule, the inheritance is very, very low. I've seen numbers like 1 in 70. I've seen numbers 1 in 100. I've seen numbers even sort of different than that. As a general rule, what sometimes is done comes with the vitamin D. There's literature out there that suggests that if you give your child at least 2,000 units of vitamin D, it reduces the chances of them getting MS. That's been written about. And then for a patient who actually has MS, it's thought that if their vitamin D level is at least 40 to 50, their chances of having an MS exacerbation is actually reduced, once again, with vitamin D. And of course, there's been debate on that at this point in time as well, but that's data that suggests that may in fact be true. But as a general rule, it is the access of vitamin D, but once again, as a general rule, most people are probably safe from this particular disorder. Now, with that being said, what is inherited? The majority of patients that have MS have other family members with other autoimmune disorders. So therefore, they may have rheumatoid arthritis instead. They may have lupus instead. They may have sarcoidosis instead. Once again, they have other autoimmune disorders. What's the common thread there? They're all autoimmune, which means that if I have rheumatoid arthritis, that means that my white blood cell system is attacking my joint. If I have lupus, it could be attacking my skin. If I have sarcoidosis, it could be attacking my heart. If I have scleroderma, my skin as well. And MS is attacking my myelin. So it's all the same immune system. The neighborhood to which there's an effect is what's different. So there would be the risk, if you will, from that point of view.
Thank you. If somebody using natalizumab tests positive for JC virus, they get up to, say, 0.75, and then they're around 0.5, 0.45 the next few times that they test over the next few months, and then they test negative 6 months later. What is that about?
Okay, so ladies and gentlemen, so this is natalizumab known as Tysabri, and for those of you that have any experience with that medication, know that we routinely check your JC virus titer. And the reason for that is that through research and time, what they've identified that if your titer is above a certain number, for some people 0.9, for some people 1.5, they're using those two numbers, 0.9 or 1.5, your risk of getting this progressive multifocal leukoencephalopathy is greater than the benefit. That's the idea. And so what this particular individual was saying, that they were tested on 4 different occasions where it was elevated at 0.4 and then 0.34 and then at some point ended up being 0, which is statistically not likely, but nevertheless, what is done? All of those numbers were less than 0.9. And so you would not have stopped their medication known as Tysabri or natalizumab in that particular circumstance. It'll be interesting, and you just monitor it, to be honest with you, in terms of what would happen clinically. Had you had above a 0.9 or above a 1.5, you would then done differently. Stop the medication more likely than not. But once again, the goal here is benefit, not risk.
What causes the black hole again? And once you have it, will it ever go away?
So to answer the last part, no. That's the easy part. The front part, okay. So imagine, if you will, that you can have inflamed areas that vary in their intensity, vary in their degree of injury. Occasionally, for some of you, you've had a MRI done, you had maybe a symptom, and the MRI showed this location. The contrast collected in that location, therefore the term enhanced was used, and then you got steroids. Months later, the scan was repeated. You come back to the doctor, you have no new symptom, you have no symptom, something you had resolved. And you look at the scan again, oh my goodness, the lesion is not there, it's gone. In theory, that lesion was a mildly inflamed location versus an extremely hot, almost malignant, if you will, lesion, to the point that regardless of steroids or not, it damaged the tissue in that region to the point it atrophied, leaving you a hole. And that's what those black holes are. And that's the idea. And so, and because we don't make new brain tissue, it repairing itself, it regenerating is not something that happens in humans.
Okay, next question's from over here.
Technology speaking, have we made any advances in imagery, new imagery, to detect or further gauge the progression of this disease?
Good question, sir, Mr. Felix. Yes and no. The MRIs, for a lot of you, you're familiar with the idea of 0.5 Tesla, 1 Tesla, 1.5 Tesla, 3 Tesla. All of those are numbers similar to the idea of regular TV, 720p, 4K, 8K, right? Detail, 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 cost more, right? Okay. So the point here, ladies and gentlemen, is that as the resolution goes up, that number gets bigger. And the details that we can see are greater. So therefore, sometimes if you get your scans intermittently, 3-4 years in between, and your first scan was a 0.5 Tesla, and then your next scan in a different location was a 3 Tesla, 6 times better, so to speak, okay? And then you see your result for the new scan, and the doctor's it's being read, and this one says you had 3 lesions, and this one says you had 17. You say, oh my God, my drug is not working. Well, the truth be told is that you had those 17 lesions on the 0.5 Tesla. It didn't show them up, okay? So sometimes your increase in number isn't that you have more lesions. Sometimes it's because the resolution of the study that was done was better, okay? There are places with 5 Tesla MRIs, 7 Tesla MRIs that exist already, and those are coming. And right now, I have a friend that works with one that's a 7 Tesla. They're seeing things, and they have no idea what they're looking at. They just know that it looks abnormal. They don't know yet because it's a new picture, it's a new finding, and they don't know its significance yet. And that's where we are to some degree as well. But will the scanners get better? Will we be able to see more? Yes, sir.
How necessary is the spinal tap for diagnostic reasons in the beginning?
Well, I love spinal taps on other people. So the question coming, guys, is how necessary is spinal tap? Occasionally, the person has an imaging study, brain scan, spinal cord included, that is just textbook classic. And then they have maybe the contrast given, and they're enhancing in all the right neighborhoods in the right pattern. Occasionally, in all honesty, you're so sure you don't use it. I, on the other hand, working at the teaching hospital, love spinal taps, love ordering them on people. So for me, it's a natural preference to get one on everybody, to be honest with you. It can give you more objective evidence, because here's the thing. As much as we don't know what causes MS, MS being decided as your condition is a matter of saying you don't have any of this other stuff, and what you're left with is MS. It's a process of excluding everything else. Well, maybe this is neuromyelitis optica. Maybe this is MOG. Maybe it's an unusual version of transverse myelitis. Maybe it's an unusual case of ADEM. These are other demyelinating disorders that mimic multiple sclerosis looks similar to multiple sclerosis, and sometimes the difference from one to the other is what you find in the spinal tap. And so occasionally it's done when you're not sure, when the presentation is more unique than you anticipate. I had a patient recently that presented with bilateral vision change, both eyes simultaneously, and a weakness in their body, and that person was diagnosed with MS. The bilateral vision thing, both eyes simultaneously, that is not a common MS presentation. It can present that way, but it is a common presentation for something called neuromyelitis optica, NMO. It is a common presentation for something called MOG. And so my point to you is that the other things that fit that pattern, in that particular circumstance, you would, as a healthcare provider, sort of insist upon a spinal tap in that case. So it depends on really how sure you are. As a patient, many of mine have asked for that. They've done their review, and they say, I want this other added information of objectiveness, if you will.
Great. Thank you very much, Dr. Walker.
Well, thank you, sir.
We're going to have you back another time just to talk visual issues. All right. Thank you very much. And again, thank you for our sponsors. Have a great night.